Welcome to the deep dive. Today, we're tackling a really core pillar of nursing, pharmacology, but specifically for real-world practice.
Exactly. We've gathered a whole set of learning objectives, kind of like a blueprint covering essentials,
Right, everything from how we think clinically, clinical judgment.
all the way to the specifics of giving medications safely across
Mhm.
different ages, different situations.
Our goal here, to pull out those crucial insights, the things that really keep patients safe, make care effective, and help you navigate what's honestly a complex part of healthcare today.
hmm And our sources take us on quite a journey. We start with the basics, the nursing process, clinical judgment, how we assess and decide.
Good.
Then we follow the life cycle of a drug. Its development, the ethics involved,
Okay.
how it actually works in the body, the kinetics and dynamics, and how that changes for kids, older adults.
And even looking at things like complementary therapies, right?
Yeah, that too.
Yeah.
And we wrap it all up, focusing on the bedrock, medication safety and quality.
So why should you, our listener, tune into this? Well, think of this deep dive as your shortcut. It's about understanding those critical pharmacology principles that honestly underpin so much of patient care.
Whether you're prepping for professional growth, just need a refresher, or maybe you just want a clearer picture of this whole area. We're aiming to distill it down.
Okay, sounds good. Let's dive right in then. The foundation, nursing process, and clinical judgment.
Yeah. And what's really key here, I think, is the increased focus on clinical judgment, especially with how the NCLEX has evolved.
Right, the next gen NCLEX.
Exactly. It's not just about recalling facts anymore. It's really evaluating how you'd think, how you'd act in, complex patient situations. That's why you see those case study questions now.
Makes sense. And central to this seems to be the idea of a concept in nursing, like pain or oxygenation.
It might sound a bit abstract, but think about it like this. Take mobility. Instead of just seeing a patient post-surgery, focusing on the concept of mobility helps us think broader. Not just can they move, but what about their pain, their fall risk? Do they need equipment?
How does it impact their independence, their recovery?
Precisely. It's about seeing that bigger picture, connecting theory to what's actually happening with the patient. It bridges that gap.
And this connects directly to the nursing process steps we all know. Assessment, diagnosis.
Absolutely. Those 5 steps, assessment, diagnosis, planning, implementation, evaluation, they line up almost perfectly with the 6 cognitive skills in the clinical judgment measurement model, the CJMM.
Okay, break that down.
So, assessment, that's recognizing cues, picking out what matters. Diagnosis is analyzing cues, understanding what those cues mean.
Planning and then becomes.
Prioritizing hypotheses,
Mhm.
figure out the patient's needs, what the main problems are. Then implementation is taking action,
In evaluation.
evaluating outcomes. Did what we do actually work? It's that continuous loop.
Got it. And in that planning stage, you mentioned smart outcomes. That feels really practical.
It is. We can't just have vague goals. They need to be specific, measurable, achievable, relevant, and time-bound. Smart.
So not just improve pain.
Right. More like patient will report pain level below 4 on a 0-10 scale within 60 minutes of receiving analgesic. It's concrete. It considers the patient's condition, their values, culture, even health literacy.
And this focus on clarity must carry over into teaching patients about their meds.
Oh, absolutely.
Sure.
Health teaching isn't just listing side effects. You have to assess if they're ready to learn first, use plain language, ditch the jargon.
Get them involved somehow.
Definitely.
Yeah.
Active involvement. And use teach back. Ask them to explain it back to you. It's the best way to check understanding.
Plus focusing on key points, maybe using written aids.
Yes, and adapting if there are literacy or language issues. And reinforcing it. It's not usually a one-time thing.
Makes sense. Okay, so the nurse's role in planning medication administration itself sounds really involved.
It is. You start by verifying the order, of course, but then you're assessing any contraindications, allergies. How's the patient right now?
Then the rights patient. Drug, dose, route, time, documentation.
The crucial checklist, yes.
Mm.
But it's patient education. Do they know why they're taking this? It's accurately documenting everything immediately.
And evaluating, is it working? Any side effects?
Right? And constantly collaborating with the team, doctors, pharmacists, everyone.
Okay, that's a solid foundation. Let's shift gears a bit. Where do these drugs even come from? And the ethics behind their development?
Right. Well, underpinning all of this in healthcare are 3 core ethical principles. You've got respect for persons, beneficence, and justice.
Okay, respect for persons.
That's about autonomy, the patient's right to decide. It demands informed consent, protecting their privacy.
Beneficence sounds like doing good.
Exactly. Minimize harm, maximize benefits. That's our duty.
Yeah.
And justice is about fairness, fair treatment, fair distribution of resources and risks.
And you can see how these apply directly to things like informed consent.
Totally. Informed consent is respecting autonomy, full disclosure of risks, benefits, alternatives, so they can choose voluntarily.
And the risk-benefit ratio is pure beneficence, right?
Yeah.
Weighing the potential good against the potential harm.
Absolutely. It's a constant calculation we're making.
These aren't just abstract ideas, though. They're codified, right? Like in the ANA Code of Ethics.
Yes, the 2015 ANA Code is really our guidepost. It has 9 main provisions.
Yeah.
Provision 1 is compassion and respect for everyone.
Okay.
Provision 2, primary commitment is to the patient. 3 is about being an advocate, protecting their safety, rights, health.
4 must be accountability.
You got it. Accountability for our own practice. 5 is interesting. It's the duty to ourselves. Maintain our own integrity, safety, competence.
That's important. What about 6?
Establishing and maintaining an ethical work environment. 7 is advancing the profession, research, policy development.
8 sounds like teamwork.
Collaboration, yes, with other health professionals and the public. And 9 is about articulating nursing values, maintaining integrity, and integrating social justice into policy.
No. And there's a provision 10, too.
Yeah, that one addresses global health engagement and responsibilities. It's really comprehensive.
It really is. Okay, so back to the drug journey. Once we have a potential drug, it goes through rigorous testing, right? Human trials.
Oh, yeah. Very structured phases. Phase on is usually small, healthy volunteers. Focus is safety, finding the right dose range.
Phase 2.
Now you're looking at effectiveness. Does it work for the intended condition? And starting to see more common side effects. This is in a larger group, patients with the condition.
Okay, then phase 3 must be bigger scale.
Much bigger. Hundreds, sometimes thousands of patients. Confirming effectiveness, monitoring side effects across a diverse population, often comparing it to standard treatments.
And phase 4, that's after it's approved.
Right. Post-marketing surveillance, it's out in the
Okay.
general public, and we're watching for long-term effects, rare side effects, how it works in different subgroups. The numbers really ramp up through the phases.
And this whole process is tightly regulated by law.
Absolutely. Key federal legislation shapes this. The Food, Drug, and Cosmetic Act back in '38 that mandated safety testing. Huge.
Then Kefauver-Harris in 62 added,
Efficacy. Drugs had to be proven effective, not just safe. That was a game changer.
then the Controlled Substances Act for abuse potential.
Right, setting up the scheduling system. Then you have the FDA Modernization Act trying to streamline approvals, and the FDA Amendments Act later gave the FDA more teeth for post-marketing safety monitoring.
It's interesting comparing that to other places, like Canada's scheduling system.
Yeah, it's a bit different. Schedule 1 is prescription only, like here. But Schedule 2 is pharmacist. Only no prescription needed, but you have to talk to the pharmacist.
Like maybe emergency contraception.
Could be, or stronger antihistamines sometimes.
Mm-hmm.
Schedule 3 is stuff you can grab off the pharmacy shelf, maybe lower dose pain relievers, and unscheduled is anything you can buy anywhere.
Fascinating. And back here in the U.S., besides federal law, we have state-level rules too, right? Nurse Practice Acts.
Critically important. These define our legal scope of practice in each state. What are we actually allowed to do? They set licensing requirements, disciplinary procedures. Ultimately, they protect the public.
And they vary state by state.
Significantly.
Yeah.
You absolutely have to know the Nurse Practice Act in the state where you're working.
Okay. Now let's talk names. Drugs have multiple names, which can be confusing.
Yeah, you got the chemical name, super technical, describes the molecule of like N-acetyl-para-aminophenol.
Okay, nobody uses that.
Right. Then the generic name, this is the official non-proprietary name, acetaminophen.
That's the one we usually learn.
Yes. And then the brand or trade name given by the manufacturer, Tylenol, Panadol.
Got it. Chemical, generic, brand.
And one more category, OTC, over the counter.
Stuff you buy without a prescription.
Exactly. Deemed safe and effective for the public if you follow the label. Think ibuprofen, diphenhydramine antacids.
Okay, so let's move into how these drugs, whether prescription or OTC, actually work inside us. Pharmacokinetics and pharmacodynamics.
Right, the two big kinetics and dynamics. But first, for oral drugs, there's even a preliminary phase,
Ooh.
the pharmaceutic phase. The pill has to disintegrate, break apart, and then dissolve into solution before it can even start to be absorbed. Doesn't apply to IVs or injections, obviously.
Okay, so after it dissolves, then kinetics.
Then pharmacokinetics, how the body handles the drug. We use ADME.
Absorption, distribution, metabolism, excretion.
You got it. Absorption, getting into the bloodstream, depends on the rate. blood flow, solubility, lots of factors.
Distribution.
Moving from the blood out to the tissues. Influenced by blood supply to tissues, and importantly, protein binding.
We'll come back to that. Metabolism.
Also called biotransformation. Mostly happens in the liver. Changing the drug, often to make it inactive or easier to get rid of.
And excretion, getting it out.
Primarily kidneys via urine, but also liver via bile, lungs, sweat, feces. Multiple routes out.
Okay, so that's ADME, what the body does to the drug. What about pharmacodynamics?
That's the flip side. What the drug does to the body. Its effects, how it works, the mechanism of action, usually involves binding to receptors.
And there are different types of receptors.
Yeah, 4 main families. Kinase-linked receptors, they activate enzymes inside the cell.
Okay.
Ligand-gated ion channels, they open or close little gates in the cell membrane, letting ions flow, causing rapid changes.
Those are nerve cells.
Often, yes. Then G protein-coupled receptors, they trigger secondary messengers inside the cell, a bit more complex.
And the last one?
Nuclear receptors, these are inside the cell. When a drug binds, they affect DNA and protein production. Slower onset, but effects can last longer.
Interesting. You mentioned protein binding under distribution. That sounds important.
Oh, it's critical. Many drugs bind to proteins in the blood, mainly albumin, but here's the key. Only the unbound or free drug can actually leave the blood and have an effect.
So if a drug is, say, 95% protein bound.
Only 5% is actually active at any given moment. That significantly affects its bioavailability, how much really gets to the target site.
And this leads to interactions.
Big time. If you give 2 drugs that are both highly protein bound, they compete for the binding sites.
One might get kicked off.
Exactly. Displaced. Suddenly you have more free, active drug of that displaced one floating around. That can easily lead to toxicity.
Wow. Okay, so that's why nurses absolutely need to look this stuff up. What key things should we find in a drug reference?
Definitely half-life, how long it takes for half the drug to be eliminated, helps determine dosing frequency.
Protein binding percentage tells you how much is active versus bound up.
Therapeutic index, absolutely crucial. That's the window between an effective dose and a toxic dose.
And a narrow therapeutic index means?
Danger zone. Very little room for error, needs close monitoring, and of course side effects, the unintended effects.
Got it. And all this relates back to potential interactions. You mentioned drug. What were the others?
Drug food, drug lab test, where a drug messes up lab results, and drug disease, where a condition like kidney failure changes how a drug works.
Let's zero in on drug interactions again. You said there were different mechanisms.
Right. 3 main types. First, pharmacokinetic interactions. One drug affects the ADME of another.
Like antacids changing stomach pH and messing with antibiotic absorption.
Classic example.
Yeah.
Or the protein binding competition we just talked about. Or one drug speeding up liver enzymes like rifampin, making warfarin less effective.
Or slowing them down.
Exactly, leading to potential toxicity. Or affecting kidney excretion. It's all about changing the movement or processing of the other drug.
Okay, type 2.
Pharmacodynamic interactions. Here, the drugs affect the body in similar or opposing ways. It could be additive.
Like Tylenol and ibuprofen together, just more pain relief.
Right, or synergistic. The combined effect is greater than the sum of the parts. Think alcohol and benzodiazepines, really dangerous CNS depression.
Or antagonistic, one blocks the other.
Perfect example. Naloxone, reversing an opioid overdose. It blocks the opioid receptor.
And the third type, pharmaceutical.
Yeah, this is a physical or chemical incompatibility before you even give the drug. Mixing 2 RV drugs that form a precipitate, or one inactivating the other in the same syringe.
Yikes. Okay, what about drug-nutrient interactions? Grapefruit juice is the famous one.
Yeah, it inhibits certain liver enzymes, boosting levels of many drugs. But there are others. Calcium-rich foods, dairy, leafy greens, nuts can bind to some antibiotics, reducing absorption.
And vitamin K?
Found in leafy greens. Fermented foods, it counteracts warfarin. So patients need consistent intake. Even timing meals around doses matters for some drugs.
And photosensitivity. Some drugs make you more prone to sunburn.
Yes. Tetracycline, sulfonamides, NSAIDs are common culprits. Patients need sunscreen and protective clothing.
So, pulling this all together for nursing practice, what are the big implications?
Fundamentally, assess kidney and liver function. They're key for metabolism and excretion. Adjust doses carefully, especially for kids and older adults. Start low and go slow is the mantra for the elderly.
Monitor closely for toxicity with those narrow therapeutic index drugs.
Absolutely. Time administration thoughtfully based on absorption factors, food interactions, and comprehensive patient education is non-negotiable. Side effects, interactions, why adherence matters, all of it.
Okay. Now, let's talk about something patients often use but might not mention. Complementary and alternative therapies, or CHAM.
Right. This is a really important area. First, the distinction. Complementary is used with conventional medicine. Alternative is used instead of.
And people use these a lot.
Very widespread, often for chronic issues, stress relief, general wellness. But the problem is, they frequently don't tell their doctors or nurses.
Which is risky, especially with herbal products, because they aren't regulated like drugs.
Exactly. They fall under DSHEA, Dietary Supplement Health and Education Act, regulated more like food. So purity, potency, consistency can be all over the place. Not the same rigorous testing.
And that leads to potential interactions.
Big potential. Especially herbs interacting with things like warfarin, insulin, antidepressants can be really dangerous or make the prescription drug not work properly.
So the nurse's role is crucial here, we have to ask.
Have to ask specifically about herbs, supplements, vitamins, and do it non-judgmentally. Then provide education based on what we know, help them make informed choices.
Are there specific herbs we should be particularly aware of regarding toxicity?
Definitely a few red flags. Kava, linked to liver toxicity, hepatotoxicity. Comfrey, also liver damage, plus it's considered a carcinogen.
Ephedra, that one was restricted, wasn't it?
Yes, because it can cause high blood pressure, stroke, heart attack. Licorice root in high doses can cause low potassium, high blood pressure.
St. John's wort.
Big one for interactions. Risk of serotonin syndrome with antidepressants, makes you photosensitive, interacts with tons of drugs. And ginkgo biloba increases bleeding risk, especially with blood thinners.
Okay. What about some commonly used herbs and their supposed benefits?
Well, St. John's wort, despite risks, is often used for mild depression. Ginger for nausea. Garlic sometimes for cholesterol or blood pressure.
Ginseng for energy.
Yeah, or stress adaptation. Ginkgo, again, often for memory or circulation. Echinacea for immune support. Peppermint for GI issues. Valerian for sleep or anxiety.
Just need to clarify terms. Botanical, herbal, phytomedicine.
Botanical is just plant-derived. Herbal usually implies medicinal use. Phytomedicine is the practice of using plant-based medicines.
Got it. Any other specific herb examples from the sources we should highlight?
Yeah, black cohosh, used for menopause symptoms, but can interact with insulin, hypoglycemics, and blood pressure meds.
Echinacea again?
Right, immune booster. But caution or avoidance needed with autoimmune disorders, HIV, TB, can overstimulate the immune system.
Kava, we mentioned liver toxicity, but also used for sleep relaxation.
Saw palmetto, often for BPH symptoms, but can cause a false negative PSA test. Big deal for prostate cancer screening.
And St. John's wort, again, besides interactions, potential for increased suicidal ideation if mixed with prescription antidepressants. Crosses the blood-brain barrier.
It's complex. That's why labels are important, though not always reliable.
What should be on a good herbal product label?
Scientific and common name, manufacturer info, dose instructions, the standard disclaimer not intended to diagnose, treat, cure, and a full ingredient list.
So, nursing implications for herbs. Ask, educate, monitor.
Absolutely. Assess use thoroughly. Educate that natural isn't always safe. Recommend reputable brands if possible. Monitor vigilantly for side effects and interactions, especially with anticoagulants, antidiabetics, antidepressants.
Document everything.
Document. And advise stopping herbs, usually a week or two before surgery, unless the provider says otherwise.
Okay. Let's pivot now to specific populations.
Yeah.
How does pharmacology change in kids?
Oh, it's vastly different. Their bodies are still developing, so pharmacokinetics ADME is unique. Absorption, for instance.
Oh, so?
Newborns have higher gastric pH, less acidic, gastric emptying is slower, GI enzymes aren't mature. All affects how oral drugs are absorbed.
Distribution different, too.
Yeah. Kids have more total body water, less body fat. Affects where drugs go. And the blood-brain barrier is less developed, especially in infants, making them more sensitive to CNS drugs.
Metabolism, liver enzymes.
Immature in newborns and infants, especially that P450 system. So slower metabolism, drugs hang around longer, might need lower doses or longer intervals.
But older kids might metabolize faster.
Sometimes, yeah. Faster than adults for certain drugs. Might need higher or more frequent doses then. It changes as they grow.
And excretion kidneys.
Also immature at birth. Lower filtration rate, less developed tubular function, slower elimination initially. The kidney function matures pretty quickly in the first year.
So these ADME differences mean the drug effects pharmacodynamics can be different too.
Definitely. Receptors might be different. Response is unpredictable sometimes. That's why pediatric dosing is almost always weight-based milligram per kg or sometimes body surface area. critical for safety.
So putting it all together for safe pediatric med admin, what's the bottom line?
Double-check calculations. Always. Use pediatric references, not adult ones. Confirm the route carefully. Use oral syringes for liquids, not spoons. Verify concentrations, they vary.
And watch closely for side effects, since they might not be able to tell you clearly.
Exactly. Plus, huge emphasis on parent-caregiver education. How to measure safe storage, finishing the course, adapt your approach to the child's developmental stage.
And be extra careful with high-risk meds.
Absolutely. Insulin, opioids, chemo, electrolytes like potassium, anticoagulants often need double checks. Okay, now let's flip to the other end of the spectrum, older adults.
Another population with unique challenges. What physiological changes affect drugs in seniors?
Lots of changes. Absorption may be less dramatically altered overall, but decreased stomach acid can affect some drugs.
Right.
Slower motility, reduced blood flow might play a small role.
Distribution seems like a bigger issue.
Often is. More body fat means fat-soluble drugs stick around longer half-life. Less body water means water-soluble drugs are more concentrated.
Then less albumin.
Yeah, decreased albumin means less protein binding, so more free active drug can increase effects or toxicity risk.
Metabolism slows down too. Liver function.
Tends to decline, especially those phase-out reactions via the P450 system. Less blood flow, less enzyme activity. Drugs metabolized by the liver hang around longer.
And excretion. Kidney function declines.
Very common. Reduced renal clearance. And remember, serum creatinine alone can be misleading in older adults due to lower muscle mass. Creatinine clearance is a much better indicator.
With all these changes, tools like the Beers criteria become really useful.
Incredibly useful. It flags potentially inappropriate medications, PIVs, for older adults' drugs where risks might outweigh benefits.
So one use is medication review, maybe deprescribing?
Exactly. Identify those PIMs, reduce risks like falls, confusion. The second key use is enhancing safety and education, informing patients and caregivers about risks, promoting monitoring, considering alternatives.
Adherence is often a big problem too, right? Polypharmacy.
Huge issue. Polypharmacy just managing multiple meds. Cognitive decline makes remembering hard. Physical limits, can they open the bottle? Read the label.
Cost can be a barrier. Side effects deter people.
Low health literacy, lack of support.
Yeah.
It all contributes.
So nursing implications here are critical. Comprehensive assessment.
Beyond just meds, check renal hepatic function, cognition, vision, hearing, dexterity. Monitor super diligently for toxicity, ADRs, therapeutic levels.
Education needs to be crystal clear.
Simple, clear. Large print, pill organizers maybe, involve family, coordinate constantly with pharmacy, prescribers reconciliation, deprescribing, maybe using just one pharmacy.
An advocate. Address cost issues, encourage lifestyle changes maybe.
Absolutely. Be their advocate. Okay, let's bring it home now. Ensuring safety and quality across the board in medication administration.
The foundation has to be the rights, right? 6 or maybe 7 now.
Yep. The core 6, right patient 2 identifiers,
Right.
right medication, check that label, right dose, verify calculation, right route, right time within the window, right documentation immediately,
And the 7th.
right indication. Is this drug actually for the right reason for this patient? Increasingly seen as vital.
But even with the rights, errors happen. What are common safety risks?
Oh, many. Wrong drug dose route errors, look-alike, sound-alike confusion, unclear orders, missing allergies or contraindications, not monitoring adequately, distractions are huge, poor communication, bad storage labeling, patient non-adherence.
It really highlights the need for a culture of safety.
Absolutely. That To Err is Human report back in '99 was a wake-up call about how common errors were and how systems needed fixing.
And the ANA is just culture.
Focuses on creating that blame-free environment for reporting errors, learning from them, but still holding people accountable for, reckless behavior. It's a balance.
And QSEN, quality and safety education for nurses, fits right in here.
Perfectly. There are competencies, patient-centered care, teamwork, EBP, quality improvement, safety, informatics. They all directly support safe med practices.
Yeah.
Using technology, working together, focusing on the patient.
Safety also extends to getting rid of meds properly.
Crucial point. Don't just flush most drugs or toss them in the trash. Environmental contamination, potential misuse.
So take-back programs.
Best option. Follow FDA and local rules. Use take-back kiosks at pharmacies, police stations. DEA has specific rules for controlled substances.
We also talked about high alert medications earlier. Extra caution needed.
Definitely. Anticoagulants, insulin, opioids, chemo, neuromuscular blockers. The risk of severe harm is high if an error occurs.
Strategies for them.
Independent double checks are common, standardized protocols, smart pumps if applicable, thorough patient ed, clear labeling, intense monitoring.
And the Nurse's Bill of Rights supports our role in safety.
It does. The right to a safe environment, adequate staffing, resources, the right to report unsafe conditions without retaliation, the right to participate in safety policy development, the right to ongoing education. All underpin safe med admin.
One more specific area, pregnancy safety regulations, the old categories A, B, C, D, X.
Yeah, those are mostly gone now. The FDA shifted to newer labeling, more detailed narrative summaries of risks during pregnancy and lactation, puts more emphasis on weighing risks versus benefits.
So the nurse's role is key in discussing this with pregnant patients.
Absolutely.
Yeah.
Evaluating that risk-benefit, educating the patient so they can make informed choices with their provider.
Okay, so ultimately it all comes back to clinical judgment, applying the nursing process to medication administration.
Exactly. Assessment, gather all the data, diagnosis to identify risks, planning, set safety goals, implementation, follow the rights, safety protocols, educate, evaluation, monitor response, side effects, adherence, adjust the plan.
And those 5 key responsibilities: right assessment, right documentation, right education, right evaluation.
And respecting the patient's right to refuse after explaining risk benefits and documenting properly. It ties it all together.
So wrapping up this deep dive, it's clear how interconnected everything is.
Yeah, the nursing process, clinical judgment, ethics, drug development, how drugs work, special populations, CM, it all feeds into safe and effective medication practices.
And pharmacology is definitely not static. It's always changing.
Continuous learning, staying current, critical thinking, they're not optional, really. They're essential for safe care.
So a final thought for you, the listener.
Yeah, try this. Think about a medication you see a lot, maybe one you take, or one you give frequently at work, based on what we've talked about today.
What are the key safety and effectiveness considerations for that specific drug? Thinking it through like that can really cement these principles.
Exactly. It makes it real and hopefully encourages you to keep digging deeper.